Hi, everybody. Good morning, good afternoon, and welcome to today's ADRC Lunch Talk. We're really excited to have Dr. Hillel Grossman give a presentation about caregiving today. And before we get started, my name is Margaret Sewell. I'm the Director of Outreach and Education in the Alzheimer's Disease Research Center. And I just wanted to introduce a couple of people before we get started. We have Dr. Maria Luizos here helping us make sure everything happens the way it's supposed to happen. And we have Dr. Judith Nugushel here, who does everything in the ADRC. And I wanted to have this opportunity to introduce Dr. Patrick Hoff, who's joining us here at the beginning, who is one of our associate directors in the ADRC.
Yeah, hi everyone. It's a pleasure to welcome you all for another great ADRC lunch. Also, perhaps in a more virtual form still this year. And as Margaret just said, I'm one of the associate directors of the ADRC, and I've been associated with the Mount Sinai ADRC for about 30 some years now. I have to say we are very grateful for your participation and are very happy to be able to continue to stay connected with our ADRC larger family and community. This is extremely important to all of us. So welcome again, and I hope you have a great time today with us. And Margaret, I will let you take it away.
Okay, thank you so much, Patrick. Thanks for joining us. As we're getting started here, I see Dr. Luizos is letting more people in the room. And so before I introduce Dr. Grossman, let me just sort of lay out what we're going to do today. After Dr. Grossman speaks, we're going to ask a couple of polling questions that we always ask in terms of your feelings about the presentation today and also people's ideas for our next lunch meeting. You could also, in addition to that, if you have other ideas and comments, to feel free to put them into the chat, which I will be monitoring. And then after that, which will just take a moment or two after Dr. Grossman's talk, we'll open up to Q&A, which we will do just to stay organized. We will handle it through the chat and get to as many people's questions as we can. So thanks again for joining us on this gorgeous fall day. And it's my pleasure to introduce Dr. Hillel Grossman, who is a geriatric psychiatrist and the co-director of the clinical core of our Alzheimer's Disease Research Center, who has been working with families of people with dementia for many, many years and has very interesting things to talk about caregiving in the world of caregiving. So welcome, Dr. Grossman. So Hillel, you need to unmute yourself.
Oh, I may have to do it for
Oh, wait, maybe Maria has to. We will let him speak.
So we got, oh, here we go.
Here we go.
Hey.
Okay, all right, thank you, Maria. So I am so happy to be here. I was speaking yesterday with two lovely friends who have been participating in the center, and they were saying, well, you know, we're looking forward to coming, but we'll miss the lunch. And I agree with that entirely, that it's great for us to have a lunchtime talk, but it would be even greater if we actually had lunch. So we owe you all, and I look forward to when we will sit down with a sandwich and have a real lunch together. what I'm would like to talk about for the next little while is something the meaning of caregiving and dementia, and I'll get to the what the title means later on in the lecture. I and Dr. Nuvershow, we usually have the role of talking about the latest in medications or medication and treatment potential. And I think there's reason why today I want to focus on caregiving. And let's go to the next slide. Okay. First, we'll do our little review about Alzheimer's disease. So I always like to show a picture of good old Dr. Alzheimer from 1906 and Augusta D, who was his patient and who then became the first described patient with Alzheimer's disease. And it took almost 100 years before someone unearthed her picture and gave a visual presence to go with the name. That was, again, over 100 years ago. And 100 years later, you'll hear people speak of an Alzheimer's epidemic that affects people famous and not famous, rich and poor, including the Oval Office a few years ago. Let's go to the next slide. And just a brief review of some of the problems that you can encounter. Sometimes they're referred to, we teach our students as, here are the A's of Alzheimer's. And they might include things like anomia, difficulty remembering names, apraxia, I'm going around that circle there, difficulty with overlearned behaviors or motor sequences like how to tie a shoe, how to button a shirt, which end of an eating utensil to use, the handle or the knife, the blade of the knife. Agnosia, which is a failure of recognition, can be recognition of faces or places. And then amnesia, the most common problem, which is memory problems. Aphasia, referring to difficulties with words or language. Let's go to the next slide. And then we've been talking about in our center, adding another A to this collection. And certainly we do in our teaching, and that A is apathy, up in that green box on top, which refers to a diminished motivation, diminished activity, kind of a loss of interest in things, a diminished spontaneity, diminished emotional expression. Carolyn Zhu, who's the head of our data core, wrote a wonderful paper a couple of years ago. And I like the title, Why Do They Just Sit? Which reflects the caregiver's frustration with this symptom of apathy. That why does the person I'm caring for, how could they just sit? And sometimes what I've seen is somebody who's sitting in front of the TV, they'll say, but the TV's not on. And again, I see the struggle there, that it's, well, how could someone be content with doing nothing? A bit of the lighter side of apathy is over there in that cartoon. Apathy is a serious problem. Well, who gives a suit? Right, kind of every lecture on apathy, there usually is a wise guy who says, well, who cares? As the first question. Okay, so these are some of the problems which might be well known to some of you that relate to the clinical expression of memory disorders and dementia. Let's go to the next slide. Okay, so my residents, when they come in, my trainees and students, and we talk about the treatment of dementia, the treatment of Alzheimer's, and they start talking about medications. And I always feel a little bit frustrated because there are very limited options. not for lack of trying. And which I want to show here is this is a slide that shows how many drugs have come to the FDA seeking approval. And this is a nice slide because it shows you from 1998 to 2017, so a nice 20-year span. You see 146, or actually 150 drugs that came to the FDA. So this is, again, to come to the FDA for approval is probably a reflection of 10 years of effort, 10 years of studies. Some of you may have participated in some of our drug studies. Of those 150, 146 were unsuccessful, meaning that they could not show that there was benefit for the patient. So, and these are just the tip of the iceberg because these are the ones that actually made it through up to what we call phase 3. Many, many more, hundreds of studies did not progress even beyond, we'd say, the basement level. And then there are 4 approved medications, or there were 4, and these are the medicines that we use. They have a modest effect. They're not good enough. And they are the reason why we are always investigating, looking for one that will make a bigger difference. Okay, let's go to the next slide. Okay, well, this led to what we might say was the controversy or the fiasco of this past summer with a medication called Aduhelm. And what I have given you here is a letter from one of the members of the expert committee who was charged with the task of reviewing this medication's suitability for the FDA. On the committee, the FDA committee, an outside expert appointed by the FDA. As you may have read in the news, this committee recommended to the FDA not to approve this medicine. They said it was not effective and its potential side effects were too high to merit anyone taking this because it doesn't have evidence of being effective. The FDA famously or infamously did approve it against the recommendations of this committee, and 3 of the committee members resigned, including Dr. Kesselheim, who wrote this letter. What I've excerpted up on the top is calling this probably the worst drug approval decision in recent US history. So this is an Alzheimer's drug, and that sort of approval has the unfortunate effect of raising everyone's hopes and then crashing them suddenly. This was followed by, go to the next slide, people who, medical facilities and systems who take care of patients had to decide what to do with this drug. So the VA, which is the largest healthcare system in the world, the Veterans Affairs medical centers, decided they would not prescribe this medication, as you see in this headline. And that was, I think, a smart response, saying that there's not enough evidence that this medicine is effective and safe, despite the FDA approval. And let's go to the next slide. And then, as the Wall Street Journal reported, the Cleveland Clinic, the Mount Sinai medical system, Providence medical system, so 2 large systems in 3 different geographies also decided that as a system of hospitals and clinics, they would not utilize this medication until it was there was a better demonstration that it actually was effective. So this is a long-winded way of saying that this is why I don't want to speak about medications today. And I want to focus on something that perhaps we don't talk about often enough, and that is caregiving. Let's go on to the next slide. Okay. Again, this is a slide that I know I've shown before. Why do we have such frustrations with our medications? And again, one possibility is that the central hypothesis, called the amyloid hypothesis, is misdirected and is not the central problem. So most of the medications that we've been looking at address this hypothesis, and it may be time to redirect our focus. Other people have said that we're giving the medication at too late a stage. We need to give it before people have symptoms, when they're likely in their 50s, even their 40s. That may be true. Oftentimes there is a call for using a stronger version of the medication, a higher dose, and then sometimes saying that, well, we have to redefine Alzheimer's. Maybe we should use only people who have a certain type of MRI demonstration of amyloid, etc. And the truth is probably a combination of all of this. Let's go on. Okay, you can see that Alzheimer's can make the headlines even of the tabloids. Doesn't necessarily mean that we're getting accurate news, but certainly people care about what is happening in Alzheimer's research, because this concerns all of us. It concerns anyone who has plans to get older than they are today, which hopefully is all of us. Let's go on. So the takeaway message is, there is no cure at present. There is no cure around the corner. Now, it's hard for me to say that, and I assume it's hard perhaps to hear that, but I know I had been saying for years and years and years, I said, because I felt this is 5 years away. I won't say that anymore. I won't say that anymore. Okay? I think the thing that we have to say clearly, and that we try to teach our residents and our fellows and our students, is that the real treatment is management, and this requires a caregiver. So caregiving is the treatment of dementias. Okay. It's an important realization, and it's something important for doctors and clinicians to say. We'll never stop using the medications that we have. We won't stop researching medications until we find one that actually works. But we need to acknowledge that caregiving is always going to be the treatment of dementia. Let's go to the next slide. Okay, so what is caregiving? In America, probably everywhere else. It can be helping people with their activities of daily living, such as bathing, toileting, dressing. It can be medication management, getting all those bottles and putting them into a pill box, making sure the pill box is filled, making sure the prescriptions are up to date, and that all the medicines are on hand. It could be scheduling appointments, remembering when those appointments are coming up, and then going to the appointments. Okay. It could be, or it usually is, in addition to the usual household chores, still is the cooking to do, and the cleaning, and the laundry, and taking care of the lawn, and taking the garbage out, etc. It could be paying the bills, remembering to do them. Sometimes there's a switch where the patient used to do that, but can't remember often enough or regularly enough, and the roles have to change, the responsibilities have to shift. And these are all things that fall upon the caregiver. Going to doctor appointments with somebody who used to go on their own, and remembering what was said. Okay? Because there needs to be a collective memory now, okay? Making decisions. Now that can be a change. Okay? And sometimes there's conflict because someone is used to making their own decisions, but they can't quite do it on their own. They need someone else's input, someone else's guidance. And this, of course, falls upon the caregiver. Let's go to the next slide. Okay, so what's the status of caregiving in our country? Well, 90% of at-home care is provided by family or unpaid caregivers. 90% of care is not home health aides. It's not people who are professional, who are doing this as their job, but it's unpaid, someone who didn't quite sign up for this, but this is now the role. There are estimated to be about 70 million family caregivers in the United States. 2/3 of them are caring for an elder relative. On average, caregiving takes up 20 hours a week, but in studies and interviews of caregivers, a substantial portion, 20%, said they were spending at least 40 hours. Again, it's not surprising. And of course, these caregivers who kind of bump into this role, no one ever gave them any training. No one ever prepared them for this. And no one, or rarely does anyone ever recognize what they are doing. Working that second job. All right, let's move on. Okay. So this can lead to something called caregiver burden, which is defined as the cumulative physical, emotional, social, and financial impact of providing care. So the caregiver burden, it varies from person to person, situation to situation. There are many factors that can influence it. We'll talk a little bit about some of those factors in the next slide. But one thing I will point out is that caregiver burden goes up when a patient has some of these things that we mentioned earlier, including apathy, as well as some of these, some other the more difficult symptoms. Let's go on. Okay, so what are some of the factors that will influence the caregiver burden? Well, the first one is, who else is helping? Okay. Is the care being provided by a spouse? And are there adult children involved? We have some families in which there are adult children, as well as a flock of grandchildren ranging in age, who all come in and help. And then we have that can be a wonderful situation. The fiscal impact of caregiving. So some of our caregivers are still trying to work their job and trying to keep all these balls in the air. The cost of the care. So if you hire a home aide for 4 hours, that's 4 hours of cost. If you need them for more, then the cost can really escalate. The emotional toll. So there's a loneliness that caregivers will describe, that I'm at home with my spouse and I feel taken away from the general world. This is exacerbated over the past year and a half of the pandemic, when it's so difficult to find a way to be out and about and with others, that this can really be an even more lonely time. Other emotions, anger, that can come up amongst good and healthy relationships. You can still get angry at the other party and say, I'm doing everything. It's not a sign of a failing relationship if one side feels angry in these circumstances. It is a sign that they need some help. Other things that increase caregiver burden, indifferent or scared healthcare providers. So sometimes our doctors and nurses, we're asking lots of questions and we're not paying attention to the most important thing, which is to turn away from the patient and look at the caregiver and say, and how are you doing? And finally, lack of purpose. And I have heard caregivers say, look, every day's the same. I'm doing the same things, and I don't know why? What's the meaning of this? Okay, let's go on. Okay, this is a complicated slide that I can barely see from where I am, so I'm going to go ahead. Okay, I just want to tell you a little story about patients that I saw a long, long time ago. Probably 20 years or more, Rita and Fred. And so Fred had a memory disorder that it was diagnosed as Alzheimer's, and it got worse over time. And with each visit, they would come in and Rita would tell me, look, this is what he did, since the last time I saw you, and would relate kind of the forgetfulness, the doing something wrong, not getting it right. And every time we met, Rita there would be new things because Fred kept on, messing up, so to speak. And one day she was telling me that, doctor, you're not going to believe what he did this time. Okay. I couldn't find his wallet. I was going to go call up the credit card companies. I was so worried someone's going to, use our cards, and I don't know what money he had in there and couldn't find it. And, I waited a week, and one day I opened the freezer to get something out, and his wallet is in the freezer. Could you believe he put his damn wallet in the freezer? So this is a long time ago. And, I wasn't very good at what I did, and I hope I've become a little bit better. And I said the wrong thing, absolutely the wrong thing. Okay. And I'll tell you how I knew it was the wrong thing after I said it. I said, Rita, you've been coming in here for months, telling me how bad his memory is and how many times he messes up. I believe he put his wallet in the freezer. What I can't believe is that you are so surprised. That is the wrong thing to say. Okay, that's the wrong thing to say. And I knew it as soon as I said it because I saw on her face how hurt she was. So I have spent a part of the past 20 some odd years thinking about her reaction and trying to understand why I said that. Okay. Let me tell you what Rita said first. Okay. She said, Doctor, I'm not surprised that he did it. I just needed to tell somebody. And here she taught me that what the caregiver needs often is just to express the anger at the situation. Okay? How could it be that this lovely man, Fred, this smart man, Fred, is putting his wallet in the freezer? In what world does that make sense? In what world is that just? And she's not asking me to answer that question. She just wants to be somewhere to say it. Rita said, if I can't tell you about it, where am I going to say this? And what I realized, if not then certainly over 20 years, is that that's my real job. To provide a space where the caregiver can express her frustration. Now, I had to learn that from Rita because what doctors learn in medical school is find a problem and fix it. And what a doctor feels when the patient tells them these things is, well, they want me to fix it. I can't fix it. So they start feeling I'm not a good enough doctor. But this has nothing to do with whether you're a good enough doctor. This has to do with a caregiver's need to be able to express their frustrations. Okay? So this is an important lesson that I learned, and an important lesson that I try and teach our students and our trainees who are taking care of people with dementias. Okay. The other important disadvantage that I think doctors bring to these situations is down on that on the right-hand side, healthcare provider concerns. Small interventions seem grossly inadequate. That doctors sometimes don't realize, or they think it's a small intervention, to sit and listen and provide that space for somebody to express themselves. That's not a small intervention, it's a big intervention. But doctors are not trained to realize this is one of the things you need to do. Small interventions don't fit the typical medical model of giving a cure or fixing it. But sometimes you have to say, I don't have a cure, I don't have a fix, but I can share the emotion. Let's go to the next slide. Okay, let me go tell you one more quick story. Okay, this is a story of a patient who had something called NPH. Okay, NPH is normal pressure hydrocephalus. So it's a brain condition that can cause dementia, but also causes incontinence. So people have lots of trouble getting to the bathroom on time. It can just flood out, and it's an additional problem. So it's a condition associated with dementia and incontinence. Now, I had a couple that I was seeing, and one visit, the spouse looked at me very sheepishly, in a very embarrassed way, and said, look, we have a problem, don't know what to do about it. Says, what's the problem? Tell me. I said, well, every night he wets the bed and he just soaks it all the way through. So I said, well, you know, do you have adult diapers? He said, we use 2 of them. And we put plastic mats on right underneath the sheets. It doesn't help. It doesn't help. Okay. Well, I remember, or then I remembered from medical school, a nurse's assistant who one day when she was taking care of a patient, I saw her take out a roll of tape, something we call paper tape, which is a tape you can put on skin. And I see her unrolling the tape and she's going over to the patient. I'm thinking, what is she doing with all that tape? And I look over there and I see she's taping around the edge of the patient's diaper. And I said, well, what are you doing that for? She says, well, this way it doesn't leak down the sides because there's always a gap and it can always get out the urine. If you tape the sides, then the diaper will just absorb it all and it won't leak. I thought, oh, really? Huh, that's an interesting thing to know. Well, that little thing that the nurse's assistant taught me is probably one of the more valuable lessons I've learned in medical school and 30 some odd years of caring for patients. So I told this couple, go to the drugstore, get something called paper tape. It doesn't hurt when you put it on skin, and tape the edges of the diaper. And of course, a month later, they come back and they've been sleeping in the same bed again. Paper tape works. Worked for them. Okay? And the point there is what I learned is you learn from those who have the knowledge. So somebody who's actually taking care of people in a hospital unit, in a nursing home, they have the knowledge. Sit and watch them and learn. And small interventions are real interventions. Paper tape costs $1.50 a roll. Okay? It's a real intervention. It makes a difference in someone's life. It allows a couple to sleep in the same bed. It's real. Okay, paper tape. Okay, let's go on. So this brings me to a term called incrementalism. Okay? Incrementalism essentially means you can do things in an incremental way and they build up. Small steps can be large achievements. That a cure doesn't come in one fell swoop. Help comes in small steps. If today was better than yesterday, then we've succeeded for today. If you can tell me today is a better day, then that's a good day. Caregiving is highly individualized, and the needs of this patient, the needs of this caregiver, have to be met in these small steps. They can be, use that paper tape on the diaper edges. Sometimes just changing the shower from one that cascades down and scares the patient to one of those handheld things you can spray, that can really be life-changing. Sometimes a volunteer coming in and visiting an hour a week can be life-changing. These small incremental steps, okay? It's different than the view of we've got a miracle cure. But we have small steps, and we do one, then we add another, and we add another, and it builds. Let's go on. And if this idea interests you, then I would refer you to a wonderful article, just the title itself, The Heroism of Incremental Care. And this is written by Atul Gawande, perhaps our greatest medical writer of today, who's actually a surgeon, who's used to the idea that, well, you cut something out and you made a cure. And of all people, a surgeon wrote, I think, this beautiful article describing the heroism and the deep value and the importance of understanding how important incremental, small steps, small interventions are. And that's from the New Yorker from January 23rd, 2017 issue. Let's go on. Okay, let's go to the next slide. Okay, so I want to just show you a little study that someone did a few years back that had this, what may be a commonsensical finding, but an important one. Loneliness increases the risk for developing Alzheimer's disease. Okay, well, that's very interesting because loneliness is not a biological condition. Loneliness is a psychological or social state of mind or state of being. And people who had this higher loneliness factor had a higher risk for developing Alzheimer's. And I find that oddly optimistic, because if loneliness increases the risk for developing Alzheimer's, well, if I can mitigate the loneliness, if I can address the loneliness, if I can help somebody be less lonely, then maybe I can decrease their risk. Okay, let's go on. Okay. And this is a complicated diagram, but it's someone else's study of this person was interested in technology, of all the technological interventions that this investigator was thinking might address loneliness. So having, various things that talk to you or that make music or sound, within your home. But again, when it comes to how do we address loneliness, we all can sit back and think, okay, well, there are many things we could do, many ways we could help someone else. Perhaps that would help us as well. Let's go on. Okay, and then I want to talk about another term. Talked about loneliness. I want to talk about something called purposefulness, having a sense of purpose. Okay? And this is work, I'm going to show you two studies that have been done by the first author there, Patricia Boyle. I take pride, though I have no right to it. Patricia Boyle was one of my trainees, probably 25 years ago. And here's an example of someone who, when your trainee becomes so much smarter, so much more accomplished, and you sit there with your mouth open and say, oh my goodness, I'm proud that just to have known her when. So Dr. Boyle has done some studies assessing someone's sense of having a purpose in life. Okay, and what she showed in her first study is that the risk of getting Alzheimer's is delayed with people who have the higher sense of purpose in life. So if you like looking at that on a graph, if you look at the bottom line with those dark circles, so that's time there. The time for these people to develop AD is delayed, and they develop at a lower rate. That's a very big difference between those two lines, the people with the high sense of purpose and the people with a low sense of purpose. Okay, so again, that having a sense of purpose delays the development of a dementia, telling us something about the importance of having a sense of purpose. So we're going to keep on talking about this. Go to the next slide. So Dr. Boyle did a second study, and this one was trying to understand, well, how does that happen? Is it that sense of purpose prevents the biology of Alzheimer's from happening? Does it prevent these plaques and tangles as we know them? Well, it turns out it doesn't do that. That's not the case. That the people with a high sense of purpose, they also get these plaques and tangles, but they don't get the cognitive decline in the same time frame with the same intensity. And that's a remarkable thing. Okay? If you want to just see Dr. Boyle speaking in her words, our study showed that people who reported greater purpose in life exhibited better cognition than people with less purpose, even as the plaques and tangles accumulated in their brains. So it protects them. It protects the patient from developing the symptoms, even if they have the brain changes, which is a remarkable study. And it was published in JAMA, perhaps the foremost medical journal in this country. Okay, let's go on. So how do we get purpose in life? How do we get purpose in life? I'd say that that's a question we all ask ourselves sometimes. Maybe we all need to ask it more often, and we need to look for role models. So I look at a picture like this, and I see an older man, perhaps helping a child to read or to learn to read or reading. And I think, well, that's purpose in life. That's purpose in life. Okay? I'm not speaking of any particular program, but that's what it looks like. I know that's what it looks like, or one aspect of how purpose in life can look. Let's go to the next slide. Look over here at this picture. Now, I'm not selling this program to you, but it's one that I know of. Okay. My daughter told me about this. It's a little program called Good Today. Choose which charity you will give 25 cents to. My daughter signed up to this. They send her 5 options every day of charities that they have located all over the world, and say, and you can allocate your 25 cents to this charity. I think, well, that's purpose in life. I mean, you think 25 cents, what's that going to do? Well, I didn't sign up for that. My daughter signed up for it 2-3 years ago. So she's been given 25 cents a day to these charities. And, I should have signed up then. It's purpose in life. Okay? It's saying, here's a cause. I'm picking which of these 5 causes do I like, and I'll give my 25 cents. Okay. I'm not telling you go do this program, but I'm using this as an example. I want to show you on the other side there what a friend of mine, GC, how he finds purpose. So he told me one day, I'm in bed. I look out my window. When I wake up in the morning, I look out the window, I see the sun has come up, and I say, thank God, I live another day. So here's finding someone who can find purpose just in the fact that they saw another sunrise. Boy, I wish I could do that. I wish I could do that. Okay. Again, another quote from GC. There is so much going on in the world. Some of it is crazy. Donald Trump? I want to be around for this. Okay. Purpose, finding purpose, finding meaning. Okay, let's go on. You all participate in the Alzheimer's Disease Research Center, in our center. Okay? Research participation is a way of having purpose. Okay? Research participation, the basis for it is altruism. So I know we participate in some studies, hopefully that this medication might provide some benefit. But we all know the real reason to do this is because you want to do good. Altruism means acting with an unselfish regard for others. And all of you who participate in our center are doing that. You are contributing to something that's bigger than any of us, which is the body of knowledge in this world. And that is a meaningful and purposeful activity. And that's why whenever we give these talks, I try and say, thank you for participating. And it feels so meager because I can't thank you for bringing purpose in the world. That's too big. It's too big. But that's what you're doing. That's what you're doing. You're acting with purpose because you're acting out of altruism. Okay? I remember asking, we have a questionnaire that we ask people who are signing up for our study. And even if the patient has, an advanced dementia, we still ask, do you want to participate? And this is what I remember one patient said to me, well, and again, he couldn't remember what the study was about, what medicine we're using, what the risks are. That he left to his spouse to understand all that. But one thing he could tell me was, it'll help other people. That's a good thing, doc. That's a good thing. What he's able to show is that he wants to be altruistic. Okay? So if you look at the other slide there, the capacity for altruism. Are people with memory disorders still capable of acting altruistically? And the answer is robustly is yes. That essential goodness that I think lives within all of us is still there. Your memory disorder doesn't take it away. And that's why people participate in studies such as these. Because there's an essential goodness and a drive to live with purpose. And I think what I'm telling you today is that this is something that living with purposefulness, the great Dr. Boyle showed us in her beautiful studies that these are things that are good for us to live with purpose. Okay, let's go on. Okay. Dr. Sano, the director of our center, did a study a few years ago. Some of you may have participated in it. This was published just a few years ago. And she looked at why people participated in this particular study. And what she found, altruism was a strong motivator for research participation. The belief that participation could help others and that it might advance the body of knowledge, this is why people participated, okay? Amongst other reasons, also amongst the hope that maybe this will bring some sort of benefit, direct or indirect. Okay? It's the participation that adds to one's sense of purpose in life. Let's go on. Okay, so we're going to end with this. It's a beautiful quote. Rosalind Carter the one-time First Lady, Jimmy Carter's wife, devoted most of her adult life to various kinds of caregiving and helping institutions or helping organizations that were advancing caregiving. And she has this beautiful quote that I want to read. There are only 4 kinds of people in this world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. So a talk about caregiving is a talk about all of us. It's about all of us, because Rosalind Carter is 100% correct. This is a talk that is important for all of us here, all of us who are engaged with the ADRC, as well as everyone we know. We'll go to one other. I think I've got one more final slide. Here's some national resources, but Dr. Sewell is sending you a local resource, 2 local resources that are much more important, and we can make those more available. And we'll go one more. And I just have to mention this because this is news of today, that in the Infrastructure Investment and Jobs Act, what had been known a little bit earlier as the American Jobs Plan, there are 2 important elements of President Biden's plan that is in Congress as we speak. There are 2 elements that are addressed to caregiving. One is to expand Medicaid, so there are more home care options, eligibility for more families, and also to increase the wages and benefit opportunities for the 2.3 million home care workers in the US. Okay, what's not in that plan, because it's already funded and in existence, is the VA has a pilot program of providing, of paying family caregivers for the work that they're doing. Okay? So people there is a realization in society that we need to do more to support caregivers. Okay, so now I'm really going to stop. That really is the last slide. And thank you very much for the opportunity to have had this conversation.
Thank you so much, Dr. Grossman. Dr. Grossman just mentioned some resources for caregivers, wonderful resources for caregivers. And what I just put in the chat, and feel free to email Dr. Luizos, who sent the invitation for today's talk, if you want more information about this. But in our ADRC, Ms. Shahan Chin, who is a social worker, provides caregiving resources and assistance for people who are already part of our ADRC. Even if you're not part of our ADRC, she can certainly provide resources and contact information. So please feel free to reach out to her. In addition to those resources Dr. Grossman mentioned. In fact, that was a question that someone had emailed me, so I'm glad you included that in your slides, Dr. Grossman, was about resources. So before I see if people have any questions, let me have Dr. Luizos pop up our poll questions. If everyone can just take a look at this on your screen. So on a scale of 1 to 5, 5 being the highest, how interesting and informative did you find this presentation today? And let us know. And also in a minute, we're going to ask about people's feedback about other lunch talks, minus, unfortunately, the lunch, as Dr. Grossman mentioned before. But if there are other topics that we're not listing, please feel free to write them in the chat, again, Dr. Luizos, you have her email because that's who sent the invite and to whom you RSVP'd with other ideas. We really do keep track of who is interested in hearing what and trying to share as many kinds of topics as we can. Okay, so I'll give you one more second. Looks like most people have answered, right, Maria?
Oh, we have almost 60% have answered.
Okay. Terrific. Okay. So if people, she's going to put up that question in a second about what you might like to hear about next. But
It's on the screen already.
Oh, is it?
Both, yep, they're both there.
Oh, I
People
don't see
answered.
it.
Mhm.
Oh, I don't see it.
Scroll.
I didn't get to pick. But if people have other questions for Dr. Grossman, feel free to put them here in the chat. Oh, here's a good question. Dr. Grossman, how would you help a caregiver, family member who's decided to move their loved one to a skilled nursing facility or an assisted living care facility if their loved one is angry, reluctant, doesn't want to go? This is a very unfortunately common scenario.
Yeah. Right. So not asking an easy question, not asking an easy question. So, you know, if someone has come to that decision, so I assume that they've been through all of the, you know, emotionally racking process of, should I do this? Should I not? And, you know, and caregivers, you know, can be just overwhelmed with guilt, which is so ironic because you're doing something that is so selfless and you're putting so much of yourself out there, and no one, as we said before, no one's recognizing it, no one's thanking you. And then you're always left with this sense, but I'm not doing enough. You know? Or maybe when someone has to go to a nursing home, there's a sense that, well, I failed. Okay? And of course, the reality is, no, this is not, you didn't fail. This is because you know, whatever the situation is, someone has a relentless disorder that is just not allowing care at home to be feasible anymore. Okay? It's because we unfortunately live in a society that provides very little to assist somebody to do this. Okay? Again, other countries of our affluence, advanced as the United States, have systems in which a home care provider is considered an entitlement. That just as you get Social Security payments in this country, you can get a 24-hour home care provider if you need it at that stage of life. There is absolutely no such thing in this country. Absolutely no such thing. And we're left with these decisions, these wrenching decisions that people who put their blood, sweat, and tears into caregiving are left feeling guilty and inadequate, feeling that I haven't done enough. I've failed at this. Okay? And that shouldn't be. And I hope that we are now at a juncture, at least as a society, with this recognition of this, and there is some change in what we understand we need to provide to people as just kind of basic services in a developed country like ours.
Well, Dr. Grossman, that leads us to the next super not easy question, which is that since we all agree that caregivers are so critical to managing and coping with dementia, why is there so little support for caregivers in this country when other countries are doing so much better than we are in caring for their elders?
Yeah. So look, I think people smarter than me have thought about this, and what they say is that if you look at what this country spends on medical care, including, what is sometimes frivolous medical care, okay? And, any of us could walk into an emergency room in the next hour, say, I have a headache, I think I should get an MRI, maybe it's a tumor. and we will get a $2,000 scan done. Okay. You know, that's not good medical care, because most people who have headaches should take Tylenol and not have an MRI. Okay. But we can do that because we're skewed towards, you know, high level, high tech medical care, and nothing in there for, well, you know, what about caregiving? You know, what about I have a headache because I was up all night taking care of my beloved, and then when come 8 o'clock in the morning, I'm on duty again, and I'm still trying to do my job, and my head is splitting. And it wouldn't cost a $2,000 scan. $2,000 would buy you a whole lot of a home health aid for, you know, for this week or next week.
Right. So let me take this one last question, Dr. Grossman. And the question is, has anyone looked at the magnitude of purposefulness? In other words, does it matter if you are donating 25 cents a day to charity, physically reading a book to a child? It's kind of like we get this question sometimes with exercise. Does it matter what you do, how much you do? And I mean, you can think about it qualitatively, but do we know anything about that?
So it's a good question. I don't know. I think it's harder to measure than exercise, but maybe exercise is a good analogy, because the more people look at exercise, okay, and look at how much exercise do you need to get those benefits, well, it keeps on boiling down. You know, so the New York Times published, you know, not too long ago, a 7-minute exercise regimen that's demonstrated to have all of the wonderful effects. Okay. You know, before that, there are a whole bunch of 20-minute, you know, so it's not a lot. And I suspect that, you know, finding a sense of purposefulness, and my suspicion is that, yeah, if you do that 25 cents a day, because it's real, okay, you know, it's a real impact. You know, that's the other thing we talked about, the incrementalism, that these small things add to each other. Okay, so we can't all fix everything ourselves, but we can all put that little piece in, and it builds.
Great, thank you. Okay, Dr. Grossman, I think we've gotten through all the questions for now. And actually, wait, someone has one last question. Let me just see. Okay, I'll see if I understand this question. If there's time, she's apologizing. What is the reaction to, I think, the McGill study, that not telling someone they have Alzheimer's disease slows the progression, and that this person is observed in their support group that that's been true? I'm not sure if you're familiar with this study.
So I'm not familiar with the study.
Well, they just gave us some great homework.
That's right. That's right. We'll have to look it up. We'll have to look it up. I think in terms of, you know, again, we'll look at this in terms of telling somebody, you know, you can tell somebody they have Alzheimer's, or you can have a long conversation about what does it mean to have Alzheimer's. Okay, and having Alzheimer's does not mean that you lose yourself. It means you have problems with your memory. That's what it means. Okay. And then the challenge is that you retain who you are. You retain your intellect, because Alzheimer's is not about your intelligence. It's about your memory. That's all. Okay? And it's not about, as we were talking before, it's not about your ability to do good things in the world, because you retain that and your desire to do good things. Okay? And as caregivers, one of our jobs, giving another job to the caregiver, but one of our jobs is that we keep the person, we remind them that Alzheimer's doesn't mean that you're not there. And it doesn't mean that you, with all your goodness, with all of your ideas, with all of your passions, is gone anywhere. Okay.
Right. Okay, so I'm gonna go ahead and stop us for today. I see we're a little bit over. Thank you everyone for staying, and thank you for coming. It was good to quote, see the way we can see each other right now. And thank you so much, Dr. Grossman, for this thoughtful presentation. I really appreciate it. And I hope everyone has a wonderful Thanksgiving, and we will be in touch soon. Our new newsletter is just about to come out, and we will be planning our next ADRC minus the lunch talk soon, and keep everyone in the loop. And thanks again for joining us. Have a great day, everybody.